My name is Dr. Amir Klein, and I've recently completed a fellowship in advanced endoscopy and research at Westmead Hospital in Sydney, Australia, under the mentorship of Professor Michael Burke. On behalf of Professor Burke and the Westmead endoscopy team, it is my pleasure to introduce you to our article on endoscopic mucosal resection of large lateral spreading lesions of the duodenum. As you know, sporadic duodenal adenomas are uncommon. They are usually incidental findings found during upper endoscopy or ERCP, which are performed for other indications. Since they have a malignant potential, they should be removed. Some of these lesions are larger than 10 millimeters. We term these lateral spreading lesions of the duodenum. They usually require resection by en bloc or piecemeal EMR for complete removal. Over the last decade, endoscopic mucosal resection has emerged as a safe and effective technique for the removal of large lateral spreading lesions of the colon. The same technique has been successfully adapted for the treatment of duodenal lateral spreading lesions. However, long-term data is limited, and large lesions seldom comprise a significant portion of reported cohorts. It should be emphasized that endoscopic mucosal resections of large lateral spreading lesions of the duodenum is at the boundary of endoscopic resection. The duodenal wall is highly vascularized, has a relatively narrow lumen, and the wall is relatively thin and fixed. In addition, some lesions are located on the medial or anterior wall of the duodenum, thus requiring the use of a side-viewing endoscope for resection. Taken together, these factors make resection in the duodenum much more challenging and complex. Over the course of several years now, we have been performing endoscopic mucosal resection in the duodenum at Westmead Hospital and following these patients prospectively. We felt that due to the paucity of data, our study can contribute to the expanding body of evidence on endoscopic mucosal resection in the duodenum, and specifically for resection of large lateral spreading lesions of the duodenum. In our study, even large lateral spreading lesions such as those greater than 40 millimeters were safely and successfully managed endoscopically with very good short and long-term outcomes. It is important to remember that with such extreme resections, adverse events are not uncommon. However, they are successfully managed endoscopically in the majority of the cases without requiring any additional surgical treatment. We believe that endoscopists performing such resections should be adequately trained in both EMR and management of complications. They should preferably be performing these resections in tertiary centers with adequate infrastructure supports such as surgical support and interventional radiology. We hope this study will enhance the understanding of the capabilities and limitations of performing EMR in the duodenum and contribute to better patient management and care. Thank you very much for your attention.